next speaker is Professor Marisa Vorster, who's the head of nuclear medicine at the University of KwaZulu-Natal in Durban, South Africa. Thank you, Professor Vorster, for making the long trip to give us a talk on sequencing alpha and beta. Will one replace the other, or do we need both? Thank you.
Good morning, colleagues. Firstly, thank you so much for this opportunity, Prof. Hoffman especially, and for the opportunity to get to see your beautiful city again. So you can see my affiliation still says University of Pretoria, which is where I started my journey and spent 15 years with Prof. Mike Sategi. But now I finally left the nest and have my own department. So according to the Times magazine, there will be a record amount of people heading to the voting polls this year, more than ever before in history. So over 64 countries will have their elections this year. And so I thought it might be worthwhile to have a sort of a mini election today. So how the procedure will work, I'll introduce the contenders with their manifestos, and then we'll look at some of the claims and examine whether we support it or not, and then summarize with an election result. So on the one corner, we have the Alpha Alliance, and the poster child here is Actinium-225. It's bigger, better, doesn't need oxygen, overcomes resistance, and act now for a big change. And then the vision is to finally get FDA approval. And so we'll look at that as well. On the other side, we have a slightly less aggressive approach, looking more at the track record that's been proven, larger numbers, longer follow-up times, counting on the FDA approval, imaging and dosimetry that's already in place. There's favorable access, availability, and cost, and there's proven great efficacy with few side effects. And to say that we go further for you. So if you look at the first claim, then clearly we know that the alphas are bigger, and they cause more damage, and they deposit this energy over a short path length, apologies. And so the analogy is between that of a ping pong ball and a bowling ball. And so of course you'll cause more damage and you'll get more DNA double-stranded breaks, which is what we want to overcome resistance, and this is why it works well after lutetium. So theoretically, we should be using this in small tumors, in micrometastases, and in diffuse involvement. But we know clinically that it works really well in larger tumors. And so we didn't expect much of a bystander effect, and we didn't expect much other effects just close to the nucleus. But now we know there is an abscopal effect, and there is quite a significant immune response that comes from that, and that we need to count on. And so in this way, I vote for alphas on this point. Now, if we look at the view to get FDA approval, this is some of the trials that have been registered now that are clinically ongoing. The major role players here seem to be actinium-led astatine, and then those are some of the popular molecules to label with. On the beta side, we know that the FDA approval is already in place, thanks to some of the brilliant work that's been done by the people in this room. So we have the VISION trial, we have therapy, and then trials like this one who will help us to sequence where targeted therapies really fit and what we can combine them best with. And so here my vote go for betas. So if we look at the versatility and the place in the treatment landscape, we know that alpha started out right at the end, where there is really no hope. Patients have gone through every form of treatment, and our Heidelberg colleagues showed us nicely with their swimmer's plot that even if you reach right at the end of the treatment landscape, you introduce it, you still get a significant survival benefit. And now if we if we look at that, then we can look at lung metastases that we can treat. These are the hopeless conditions, really. And you can see after this one treatment, you get an excellent response. Also for brain metastases, after one treatment of actinium PSMA, you get a brilliant response. But now if we level the playing field, if we make it a bit more fair and we bring it earlier and early, like we spoke about yesterday, Then we try it in the post-ADT setting, and we try it in the hormone-sensitive setting, and we even go as far as treating in the chemotherapy-naive setting. And this has been nicely demonstrated by my mentor and friend, Prof. Mike Satege, and with excellent results. You can see that all these comparisons show you a dramatic serum PSA response and an improved over progression-free survival. So now if you look at the same thing for the betas, it's like it has lagged slightly. So now this kind of evidence is coming to light as well. We have talked about this yesterday. And now we can also see that if you bring it earlier, even in the taxane-naive patients, you can also get a significant treatment response. And so now we have several meta-analyses appearing. There are 4 recent meta-analyses for actinium PSMA. And all of them really, they overlap quite significantly, so many of the same studies have been included in them. But they all say we have an excellent serum PSA response and we mostly get xerostomia. And this has been echoed more or less by the warmth data. So here we know the progression-free survival is around, when you look at the meta-analysis, it's around 9 months, and overall survival is in the range of 12 months. So as I said, the side effects mostly between 7 and 80% will get xerostomia. And the other effects that we need to be expecting are bone marrow related and renal toxicity as we expect. But these tend to be grade 1 and 2, and grade 3 seems to be around 3% of patients. So looking at the same for beta, here we look more at the bone marrow effects. We know that we get a good response in the serum PSA decline. Looking at the side effects, these are related to anemia, leukopenia, and thrombocytopenia. And even though we do see the xerostomia, it is far less common. Then imaging in dosimetry, which we know is really a big problem with alphas. So you can image it, and we have done this at our center, but it's very impractical. So you take about 40 minutes and you get one pelvic image, which is not quite good. So you can't even see the kidneys yet or the salivary glands. Now from beta, we know we get excellent images post-therapy, and we need it. We confirm our target. We can use it for follow-up, as we discussed yesterday. And we know that the tumors get the higher dose, 3 to 6 times more than the critical organs, which are the lacrimal glands and the salivary glands. So on this point, obviously the betas win. Next, we have international high-quality guideline, which we spoke about quite a bit. And this tells us which patients we can choose, how should we treat them exactly, and what are the consequences that we can get, that we can expect. On the other hand, we have approaches, practical approaches to alpha therapies and how we should administer them. So clearly we don't have international guidelines or any standardization yet. And so betas have to get the vote. Now, if you look at the support and the interest, there is clearly great support and interest in alpha emitters, especially if you look at the publications from the last 7 years or so, and this is projected to be even higher. On the beta side, you get a similar trend, but slightly less exciting. And then if you look at how industry is interested in producing alpha emitters, just over 15 interested in producing and supplying lead, that already speaks volumes. And so on this point, I'll award the vote to alphas. But why can we not have both? Why do we have to choose? And as you know, many colleagues have treated in tandem and used both of these. The logistics of it is not quite clearly defined, so some use higher doses of actinium at the beginning and de-escalating, or vice versa, give it together or intermittent. So here we still need clear guidelines. In my center, we've often had to treat like this, not because it was planned necessarily, but because of access and availability. So sometimes it's not delivered and we need to change to the other one. But these approaches work really well from preliminary data, and it serves the salivary glands to some extent. And so I would vote for a coalition. So we know that to optimize our patient care, we have to combine it with various conventional forms of therapies. And this still has to be sorted out, and we've spoken about that a lot these past few days. Also on the beta side, we now see even a meta-analysis combining with third-line chemotherapy and showing this overall survival and a PSA response. So if we look at the scoreboard, it looks like betas are still winning, but only just. And this is just my opinion, but it's basically based on the safety and efficacy, which is there. It has a better track record. Both of them are quite versatile. We have the clinical trials and the FDA approval. We have good imaging and dosimetry, which we need. Maybe the interest and support isn't as much as with alphas, but the access and availability is far better than with alphas. So in this case, I think we really are looking at a coalition, and we definitely don't have to choose between the two. And I thank you for your attention.